So one of the hottest things in sexual medicine these days is this concept of stem cells, Shockwave, PRP. It's really taken off. And I really want to show you where the data is on this and where we're going with these types of technologies. So again, here are my disclosures. And I do receive research support from a company called Tissue Genesis that does make stem cells to treat erectile dysfunction. So just a little bit of history about ED. I mean, look, we've been treating erectile dysfunction for thousands of years. Even if you look at the ancient manuscripts, 2600 BC, they talked about using these potions to cure impotence. In fact, if you looked at the Egyptians, they did something very interesting. They would take crocodile hearts mixed with wood oil, and they would rub that oil onto the penis, and these men would get erections. It was probably more the rubbing than the oil, but it did work, right? And then back in the 8th century, they talked about ingestion of goat tissue, testes tissue for erectile dysfunction. We also know that we didn't realize that this could be a neurogenic problem till the 1800s, where Eckert showed us that this could be a neurologic cause. Dorsal vein ligation in the 1800s. Testosterone was synthesized in 1935. We started looking at intracorporeal prosthetic implants really in the early 1950s and 1960s, but really the Scott inflatable penile prosthesis was 1973, which really revolutionized the treatment of ED. Intracavernosal injection therapy was accidentally invented by Dr. Virag, who injected it and later on into himself. We also know that in 1998 we had Viagra. So a long history, but what I'm trying to illustrate here, if you look besides the penile prosthesis, really we don't have a true cure for ED, right? Everything I'm giving you, Viagra's not a cure for ED. Viagra's going to solve your problem for 8 hours, but it's not solving the fact that every year your disease is getting worse and eventually Viagra's going to stop working, right? So there's not a true cure or reversal for ED. I was fortunate enough to be in part of the AUA Guidelines, which came out last year in 2018. This was our third iteration of the ED Guidelines. I'd like to share with you some important points off this. This is our old paradigm, and this is what we used to think of in the old days. A patient walks in, we start with first-line therapy, give them a PD-5 inhibitor. Then you go to second-line therapy if it fails. Give them a suppository, an injection, a pump. If that doesn't work, move on into a penile implant or corrective surgery, right? So you had to follow this paradigm of 1, 2, 3, but that is no longer the case. The new guidelines state that a patient walks in and you use this concept of shared decision-making. I tell them about all of the options, PD-5 inhibitors, vacuum, injection, penile prosthesis. And if a patient chooses and says, I don't want to start with the PD-5 inhibitor, I want to start with intracavernosal injection therapy, that is completely acceptable if you've gone through the risks and benefits of each of the options. This time when we made the guidelines, we do have stress heavily on lifestyle modification. There is excellent data to suggest that diet and exercise alone will significantly reverse the ED process, right? Sleep can help improve ED and stress modification. So I tell my patients the 4 pillars: diet, exercise, sleep, and stress reduction. Each one of them independently can improve your erectile function, and we should take it seriously. And the other important differentiator you'll see this year in the guidelines is that of the concern for cardiovascular risk. Those patients who come in, remember, ED is the first sign of a heart attack or stroke. If a man walks in today and develops ED, 15% of them will have a heart attack or stroke within 7 years, so we take it very seriously. A man who walks in with ED and 2 cardiac risk factors really should be thinking about a cardiac evaluation for the risk of occult cardiovascular disease. So we tell the residents again, what are the tests you want to get? You want to get a hemoglobin A1C, testosterone, and a lipid panel. You want to make sure that the testosterone, if it's less than 300, you consider for therapy. Now, realize that on the guidelines, it's pretty interesting what they say about testosterone. So men with ED and testosterone deficiency who are considering ED treatment with a PD-5 inhibitor should be informed that PD-5 inhibitors may be more effective if they're combined with testosterone therapy. And that is true. That is a guideline statement, moderate recommendation. So a patient who's not responding well to a PD-5 inhibitor, who's hypogonadal, may become a responder anywhere from 30 to 50% if you start them on testosterone supplementation. But the guidelines also state that men should be advised that testosterone therapy is not an effective monotherapy for ED. If a man's goal is to ameliorate ED symptoms, he should be counseled regarding the need for ED therapies in addition to testosterone therapy. So in other words, if a man walks in, he has ED, the guidelines are saying you're not going to offer him testosterone as monotherapy and say start with this, right? You can offer it in conjunction with a PDE5 inhibitor. Now, I would argue that there are 3 exceptions, and the 3 exceptions in our practice are young patients do tend to respond to PDE5 inhibitors, testosterone therapy to some degree with monotherapy, patients with very low baseline testosterone levels, and men with mild ED do tend to respond quite well as monotherapy. So, as I mentioned earlier, if you ask patients, what's the most important consideration for ED medications, they say, there's no cure. If there was a cure for my ED, I wish there was a cure, right? And then what's the most common reason for stopping the medication? It stopped working. It's no longer effective. So there's this race, this search to look for a cure to treat erectile dysfunction. So I'll start with the first one, shockwave therapy to treat ED. And I'll be the first to tell you 5 years ago when I heard this, I said, this makes no sense at all. This is ridiculous. It was presented at the SMSNA, and I said, this doesn't work. But quite honestly, if you look more carefully at this, more and more data is emerging that there may be some true scientific merit into this type of technology. So shockwave therapy has been used for a lot of other conditions, for plantar fasciitis, Achilles tendonitis, and the best literature I've seen really is in the cardiac literature, where you look at myocardial revascularization, where they shock the heart and you increase new blood supply into the myocardium. So what is the concept of shockwave therapy? So as urologists, we know what shockwaves are for lithotripsy. Again, it's a very high pulse, a high amount of pressure over a short period of time. But remember, the pressure for lithotripsy can be quite high. We're looking at anywhere from 50 to 100 megapascal. For low-intensity shockwave therapy, which is what this is called today I'm describing, or LIST, it's anywhere from 5 to 10 megapascal. So again, ESWL is not LIST or a shockwave therapy that we're talking about today. When we look about shockwave therapy that I'm talking about today, at low levels, we induce cell regeneration. It helps with pain as well. At higher levels, we're looking for tissue destruction. We're trying to destroy, for example, a stone. So we're looking at low-intensity shockwave therapy. Now look, there are numerous machines out there. And the main categories you want to remember are there's the electrohydraulic, then there's the electromagnetic, then there's a piezoelectric, and then there's a pneumatic. And now my only advice to you is just you want to stay away from the pneumatic. The pneumatic, in my opinion, does not do anything. But it's very difficult to compare these because we don't have enough data to compare the electrohydraulic to the electromagnetic. At Baylor, we just purchased the electrohydraulic. We will be starting our trials in October next month with the electrohydraulic. But again, I cannot tell you that one is necessarily better than the other. But what I do want you to stay away from is the pneumatic, okay? The pneumatic is just literally like taking a vibrator and putting it on the hand. That's all it is, or on the penis. That's it. The FDA has classified these as Class 1, which means they do not have to be monitored because there's no safety concerns. So many of these pneumatic machines will sell for about $20,000. Many of the more electromagnetic or electrohydraulic machines will sell for $60,000 or $80,000. But at the end of the day, both machines make a shock sound and make a pulse. So patients don't know the difference, right? So the sad thing is that the majority of machines sold in America are the pneumatic, right? They're the pneumatic. And what do they get charged? They get charged $500 to $1,000 a shock for 6 shocks, right? So you spend $20,000 and you give 6 shocks to a patient, you get $6,000, and you keep running the machine all day. Right? And that's what's going on in the United States. This is big business. And unfortunately, patients don't know the difference between the different types of machines. So there is excellent data on the mechanism of how this works. Remember that when you shock and induce a shock, you actually recruit stem cells. So for many years in my practice, in my research, we've been trying to give men stem cells through adipose tissue. But when you induce a shock, you actually recruit stem cells. You recruit new blood supply. You recruit wound healing. The best example I can give you is if I take your finger, I take a hammer and start hitting your finger over and over again, what's going to happen? Your finger thinks it's undergoing trauma. And what is your finger going to do? It's going to start bringing in new blood supply. It's going to bring in new growth factors. It's going to try to heal the finger, and many of those blood supplies stay after the injury. So again, that's exactly what we're trying to do with shockwave therapy, is to induce neoangiogenesis into the penile tissue. There have been several randomized controlled trials, and the AUA guidelines came out last year, but we have had a lot of data coming out over the past 12 to 18 months. And most of the data would suggest, and if you look at the column here, is that the change in IIEF, and remember that you have to have a 4-point change to be clinically significant, would suggest that there is benefit in giving these men shockwave therapy for the treatment of erectile dysfunction. In fact, if you look at one of the largest meta-analysis, if you look, majority of these studies, 6 trials, show significant benefit of shockwave therapy over placebo. The only problem is that nobody knows how many shocks to give, nobody knows how often to give them, and when to give them. We're all just trying to figure it out, right? So you hear all types of protocols. The ones that didn't work were the ones that gave lower number of shocks, 600 shocks. Typically, patients are getting 1,500, 3,000, or 5,000 a shock. But when you do go lower on the number of shocks, it tends to be less effective. Now, the AUA guidelines is pretty strict, and when we put this out there, we didn't have the data that we have today, but the guidelines state that for men with ED, low-intensity corporal shockwave therapy should be considered investigational at this point. What about this concept of stem cells? Still a very hot topic. Many patients are getting stem cells to treat erectile dysfunction. The cost can be anywhere from $10,000 to $15,000 to give men stem cell therapy for ED. If you look at the animal studies, very convincing. Diabetic rat model, cavernous or nerve injury model, yes, it's effective in improving overall erectile function. In fact, if you look at the basic science at the mechanism, if you put stem cells into the penile tissue, it actually preserves cavernosal smooth muscle. It actually can prevent fibrosis of the cavernosal smooth muscle, and it can actually improve cavernosal nerve regeneration and growth. So if you're thinking about a post-prostatectomy rehab model, this is phenomenal because these are the 3 areas that we focused on for so many years to improve erectile function. So the problem I have with it is this, is that there are very few studies, cases of 7 patients, 8, 17, 12 patients. I'll show you mine today as well. And let me be very clear, no randomized placebo-controlled trials, not one. Not a single randomized placebo-controlled trial with stem cells to treat ED. And so we published this several years ago, is that you have to be careful when you're charging $10,000 to $15,000 for a technology that has not a single randomized placebo-controlled trial and making the claim that it will cure erectile dysfunction. And the FDA feels the same way. So several years ago, the FDA has now prohibited use of stem cells to treat ED unless it's in a trial. Right, if you're in a clinical trial, you can use it. So many of these companies have moved to South America, Panama, the Bahamas, Mexico. You can go down there and get them, but you can't get them here in the United States unless it's in a clinical trial. So the AUA guidelines are very clear. For men with ED, stem cell therapy should be considered investigational. Now today I'd like to share with you a study that we finished at Baylor. We finished the first and only FDA-approved trial to treat men for erectile dysfunction with stem cells. This was a feasibility study and was a 12-month follow-up. We used a machine called the Accelerator, which was made by Tissue Genesis. And essentially what I would do is I would take 50 to 60 cc's of fat from the abdomen. I would place it inside the Accelerator. Within 1.5 to 2 hours, it would give me anywhere from 37 to 50 million stem cells. I would take those stem cells and I would inject it back into the penile tissue and see if it would help reverse or treat the ED process. So this study, we call it the Phase 2A study. It was a prospective multi-center. It was 2 centers, 2-arm study. We had 30 patients. 20 patients received the treatment. 10 patients were just control. We'd follow them. They would just receive normal PD-5 inhibitors, and then we'd let them cross over into the treatment arm. And so these patients had to have at least a mild degree of ED or better or greater for at least 6 months. So there were 2 sites, Dr. Goldstein's site in California. It was our site in Houston. And you couldn't have a history of pelvic radiation. You couldn't be taking concomitant medications for anti-androgens. You had to have a normal testosterone value in order to participate, and no penile abnormalities such as Peyronie's or histiopriapism. So we had, in terms of adverse events, this is pretty safe, to be honest with you. So in other words, we had 21 subjects who reported 58 adverse events, but these are all anticipated. The most common adverse events you'll see with stem cells is either pain, bruising, or swelling at the injection site, but pretty benign. This is our initial data. We just published this in June of 2019, and you can look at the treatment arm here in orange. We do start seeing an improvement in erectile function. The maximum we saw was at 9 months, which gave us an improvement about 4 on the IIEF, but at 12 months and as we go further, it doesn't seem to be as durable. And so my thought would be that maybe I need a booster. Maybe I need to give multiple injections at different times, because this was only one injection at one time. The problem with giving multiple injections with this type of technology is that it's logistically a little tricky and it's expensive, and I'll show you why. So this was the phase 2A that we created and we finished. Now we're going to be starting phase 2B pretty soon, and the difference between our phase 2A and 2B is I'm going to have 60 patients in this study. It will be blinded, and we will have a sham, so it'll be a sham-controlled study. And it will be 12 months instead of 6 months, and we will be getting duplex ultrasound to have some objective data in these patients as well. So this will be starting hopefully in December, but we still soon to find out. So this is why I said it was logistically a little tricky. So what I had to do was, in my study, I had to put the patients to sleep. So then I had OR costs. I had a plastic surgeon do liposuction. We would get about 50 cc's of fat, and then we would then put it into these machines in the back of the room called the accelerator. So if in terms of cost, in terms of logistics, if I had to do this every 6 months, it doesn't seem very practical, right? So we have to figure out an easier way to get the stem cells. We didn't culture the stem cells, so some people will take about 10 cc's of fat and they'll culture them multiple times, and we feel that you lose the efficacy when you culture them. We like them fresh. So again, we just have to work out the logistics of maybe an easier way to do this. But remember that the problem with injecting into the penile tissue is that the corpora is just one big venous sinusoid. So you inject it in, it's right out, right? So you have to apply tourniquet. You have to leave it there for 30 minutes. We injected a total of 30 cc's, 15 on each side. It's quite a bit of fluid with 50 million stem cells into the penile tissue. And the last one is this concept of platelet-rich plasma, PRP. Your patients may ask about it, and they may use the term the priapus shot or the P shot. And when they say that, this is what they're referring to, is platelet-rich plasma. Now, I'll tell you, this is extremely easy to do. All you do is you take 10 cc's of blood, you centrifuge it, you take the supernatant, you centrifuge it again, and put a little bit of calcium chloride, and now you have PRP. And the reality is it costs about $50 to make this, but the going rate is $1,500 to $3,000 an injection in the community, right? But it's unbelievably easy to make this. So there are no studies listed on the clinicaltrials.gov website. In fact, if you Google it, there's 147,000 claims of PRP, but there are no trials on PRP, right? So they talk about bigger erections, improved sex life, orgasmic function. As I mentioned earlier, the cost is anywhere from $1,500 to $3,000 per injection. And the very first study ever published on this was actually in 2018 by Ryan Terlicki's group, which basically just had a small case report of 5 patients. So 4 patients with ED, 1 with Peyronie's. They received PRP and they had some improvement. That's it. That's all the data we have on this big movement that PRP improves overall erectile function. And if you go to websites, there are thousands of websites that will tell you that if you get the priapus shot, firmer, larger, better erections, the priapus shot will last 18 months at least. No data to support that, but it'll last 18 months. And again, just be very careful when these patients are asking for the priapus shot. So again, the AUA has stated that for men with ED, PRP should only be considered experimental, not investigational. I'm part of the SMSNA. I'm the secretary. We actually put out a statement in 2018. We believe that the use of Shockwave, stem cell, and PRP is experimental and should be used in compliance with IRB approval. And we also put a statement in there that the SMSNA advocates that patients involved in these clinical trials should not incur more than the basic costs for their participation. So in conclusion, current ED therapies do not provide a cure for ED. The mechanisms for how PRP stem cells enlist improved erectile dysfunction appear to be promising, and some initial studies have demonstrated benefit. But at this time, the use of LIST stem cells or PRP should be considered experimental until more randomized, placebo-controlled trials demonstrate proven efficacy and safety. Thank you for your attention.